Everyone. Welcome to our webinar on working in rural, remote, and coastal areas. I'm Beena. I'm a consultant psychiatrist and psychotherapist. I'm also the Director of Medical Education for Lincolnshire Partnership NHS Foundation Trust. And before we start, let's do some housekeeping. If you have any questions, please write it in the Q&A sections. If you just want to chat, please write it in the chat box, and we'll get started. So, Georgia will put up my slides. Okay, so rural, remote, and coastal mental health and medical education. Okay, next slide. My agenda is just to set the scene, to think about the impact of mental health care difficulties in rural and coastal areas, which is quite different, and to look at the inequalities in the provision of mental health care in rural and coastal areas, and to think about specifically about, as a local education provider, providing medical education in a rural and coastal mental health trust, what are the challenges we have? So to look at this problem from and through the lens of medical education. It's all about the trainees. So what is the experience of trainees in a rural trust? And to perhaps begin to think about opportunities and the way forward in addressing this issue. Next. We must acknowledge that when we are talking about the rural and coastal areas in the four nations, we're talking about a very diverse group of geographies, diverse group of population needs, and therefore one size does not fit all. There's a lot of differences. Next. I don't know, this is a picture of Skegness. When you see a picture of the rural and the coastal area, just the coastal countryside, I don't know what feelings come up for you, what that evokes for you, but generally it's a sense of joy, a sense of relaxation, a sense of well-being, and a sense of almost going into holiday mode, yeah? But what the 2021 CMO report has shown us is that this is just a facade. What lies beneath this facade is a hidden story of despair. Next. The life expectancy, the healthy life expectancy, the disability-free life expectancy are much lower, and the standardized mortality rate are higher for people living in rural and coastal areas. So there is a risk of living a far shorter life in poorer health and getting old before their time for certain populations in rural and coastal areas. Next. This is, if we look at specifically around issues of social and economic deprivation, if we look at East Lincolnshire, for example, there are long-standing difficulties with employment. There is a whole part of the population who rely on tourism, which can be very scanty and very patchy and seasonal. So there is a real sense of social and economic deprivation, which has a direct impact on both mental and physical health. Smoking is 6.7% higher. Smoking amongst pregnant women is 20.6% in rural and coastal areas, whereas it's 10.4% in the rest of England. Alcohol-related admissions in those less than 18 years is higher. Substance misuse in a place like Hull is 18.9%, whereas in the rest of England, it's 8.1%. Next. If we look at the demographics of this area, There is a higher proportion of elderly residents over the age of 65. And if we look at the migration groups, the people going into these areas, they tend to be people who are vulnerable, who are looking for cheap housing, and a transient migration group. Whereas if you look at people who are migrating out of this area, they tend to be young, qualified people with who are looking for stable, suitable jobs, who want to be a part of a stable workforce. Next. And as we've seen, sorry, yes. And if we've seen that there's a higher proportion of elderly people living in these areas. And if you look at long-term mental health problems like dementia and depression, there's a higher prevalence of long-term mental health problems for people living in rural and coastal areas. And if we specifically look at self-harm among children and young adults aged between 10 and 24, the rates of self-harm is higher in people in this age group for young children and young adults living in coastal areas. Next. If we think about the availability of mental health services in the wide community, in the wide countryside, services tend to be disseminated, and there is particular difficulty with recruitment and retention of staff. And therefore, setting up a service, you need a critical mass of staff to both set up a service and to run and sustain that service. And that there is a difficulty with that. So if we look at difficulties in recruitment and retention of consultants, it's this difficulty in recruitment of retention and recruitment is across all medical grades. So we have 15% fewer consultants per head population, and we also have trainees, 14.6% fewer postgrad trainees. In 2019, the Royal College of Physicians said that their recruitment of consultants in rural areas was 13%, 1-3, and the recruitment of consultants in urban services was 87%. I looked for similar statistics and data in psychiatry, and I couldn't find it. Next slide. If we think about accessibility of service, the services tend to be disseminated, and the public transport tends to be poor. I trained in urban city like Nottingham, and the public transport is excellent. And the waiting time for a taxi at any point of the day or night is about 5 to 10 minutes. Here, in Lincolnshire, the public transport is very poor, and the waiting time for a taxi during the peak hours in the morning and the evening when there's school drop-offs can be anything between 1 to 3 hours. Services are disseminated, and the difficulty in recruitment and retention is not just with psychiatrists, career psychiatrists or psychiatry trainees, but it also extends to our colleagues from other disciplines like psychology, nurses, and so on. So the obvious solution in today's digital savvy world is to have online clinics to address this difficulty with transport. However, in rural and coastal areas, the digital literacy is poor, and hence the intake, the use of online clinics is poor. Next. And if you look at the acceptability of having mental health problems, the stigma around mental health services in rural and coastal areas tend to be higher, and the mental health literacy tends to be poorer. We know that in England, at least every week, we have one farmer who commits suicide. But the willingness to identify and accept having mental health problems and seek help continues to be poor. Next. If we take places like Blackpool, Hartlepool, Hull, and so on, their social deprivation index is high. So there's a high level of social and economic deprivation. But if we look at their staffing per head population, it's also good. But if we look at these 5 areas have been identified as the areas with the most amount of social deprivation with the lowest staffing level per head population, and that includes East Lincolnshire. Next. If we look at the inequalities in medical education, we know that the trainee posts tend historically have been concentrated in urban areas like London. And we know that when there is a concentration of trainee posts in urban areas, the LDA monies and the resources follow the posts. So if we look at there is these areas, these urban areas, urban training centers are historically are seen as the areas of training excellence because of higher number of trainers, more specialty training opportunities, tertiary centers, and so on. Whereas rural areas, rural training centers there is a risk of being, it's historically, they've been seen as the backward waters of medical education. Next. If we take Lincolnshire itself, there is a very clear east-west divide. In the east, in areas like, as you can see, Louth, Mablethorpe, Skegness, these coastal areas tend to have more of economic and social deprivation, and the recruitment and retention of staff has been particularly poor in the East Coast when compared to the west of Lincolnshire, like Lincoln or Grantham or Sleaford. Yeah. And that's the recruitment and retention of staff is both for trainers, consultants, and also trainees who are training in posts. Next slide. Skegness and Mablethorpe, 1/3 of the residents have no or low qualification, and at least 42% of them are on benefits. If we look at those over 65 in these areas, we have about 32% of elderly people, whereas in the rest of England, it is 18%. Yeah. Next slide. If we look at the experience of trainee doctors, I wanted to do a survey looking at the experience of trainee doctors, and I couldn't find any specific survey. So this was a survey that was done by a medical student from Lincoln Medical School as a part of a BMedSci project. And this looked at, as a part of a BMedSci project, and she published it. So she looked at the response rate was 60%, 74% of the trainees were international medical graduates, 16% UK qualified, 61% of them were between the ages of 24 to 36, and 11% of trainees lived with families, and 89% lived alone. Next slide. And if we look at what they saw as these trainees rotated between rural Lincolnshire and our neighbouring urban trusts. And if we look at the unfavourable factors, what came out first was transport. 87% of them said that they had a worse experience with transport when compared to previous placements. Next. And the mean transport time was 1 hour. What we have tried to do is we've tried to address this by making all our work sites single site jobs. We've changed our job description. So during their work hours, trainees don't have to travel between multiple sites. Most jobs are single site jobs, except 6 jobs, which we couldn't because of practical reasons. And of course, during on-calls, they can use taxis and yes, they can use taxis. And this is something that we try to facilitate to address the challenges with transport. Next. And everything, including psychotherapy supervision, Balint Group, postgrad, everything is online. The second unfavorable factor was social life in Lincolnshire. We came across badly with social life, with trainees complaining about zero nightlife. Lincolnshire's too empty, small city, nothing to do, too quiet, sleepy town. Well, this is something that we have little control over. We can't build a shiny nightclub. But I suppose it's about celebrating what we do have. We are a beautiful, county which has a lot of countryside, and it's about celebrating the aspects of the country that's beautiful, perhaps walking in the countryside and cycling and so on. Next. Loneliness. About 1/3 of the trainees said that they felt more lonely. We've tried to address this by organizing social events, mentors for trainees, both consultant mentors and peer mentors. Next. Where we came across as favorable, a small margin of trainees felt the housing costs and cost of living was much better, 52%. Next. What was another favorable factor was 91% of trainees felt that the workload and work-life balance was much better than when compared to the neighboring trusts. Next. With 87% of the trainees felt that they had more support and better support from supervisors in our trust than in previous jobs. Next. So that we know about the NHSE program in addressing inequalities in rural and coastal areas. They've looked at 3 areas. I'm going to focus on the first one, which was widening participation in and access to medical school with the ambition of increasing applications from rural communities. In Lincoln in 2018, we started the Lincoln Medical School. We have the Lincoln Training Academy, which does in-reach to the schools in the East Coast, trying to recruit students to medical school. But this has been complex because of social issues, because of difficulties with tuition fees and travel and so on. Next. What has really made an impact was changing the training posts in rural areas. So there was a redistribution of training posts so that the training posts are all not London-centric. And we had the opportunity to expand our training posts, which we really took. So we've gone from having 26 trainees to having 46 trainees. We've doubled the number of CTs, tripled the number of ST trainees. And why is this important? This is important because what we know is 50% of trainees of doctors settle within 50 miles of a medical school. 80% of our ST trainees are likely to choose consultant jobs 50 miles of where they trained and 50% within 10 miles. This is very important in addressing the issue of recruitment and retention. And because we are growing our own doctors and building our workforce for tomorrow. We've started seeing the benefits of that. Last year, we were able to recruit 3 STs into consultant jobs. Fingers crossed, this year, we are hoping to recruit 3 more. And of course, LEPs have to adapt to issues with rurality, different challenges with rurality like transport, making our placements more attractive, supporting our educators with robust job planning, and having educators forum and protected time for them to offer supervision, opportunities with research. We have our research development forum in collaboration with Lincoln University and so on. Next. But all of this is at its early and developmental stage. What needs to be done is trainees who do placements in a rural mental health care trust need to have an understanding of the mental health care needs of the community in which they live in and understand how to work with them. This has to be included in the curriculum and incentivizing educators, not with London waiting, but East Lincolnshire waiting for trainers who work in trainer colleagues who work in East Lincolnshire is important. We know that remuneration is a very powerful incentive. Next. In conclusion, I think that there is significant inequalities in the provision of mental health care in rural and coastal regions, and the strand of growing our own doctors and the medical education strand in addressing this problem is a very, very important strand. And the steps that the NHS England have taken is certainly in the right direction. It feels that we're not where we used to be, but we're certainly not where we would like to be. Thank you. Okay, so I'll move on to the next speaker, who is Dr. Greenall. Dr. Greenall is a consultant psychiatrist working in Lincolnshire Partnership NHS Foundation Trust. He's been a consultant psychiatrist. He's a very psychologically minded consultant psychiatrist who has a special interest in trauma-informed care. He works in the women's ward. And he's also a very passionate educator, and he's the associate clinical director. So, and a delightful colleague. So over to Toby.
Thanks so much, Veena, and welcome everyone. I just wanted to give everyone a brief rundown of my training experience. I had a split training experience. I did core training in London and then moved up to Lincolnshire and the East Midlands for my higher training. So we just wanted to give a flavour of some of the challenges, some of the positives and negatives of that experience, to highlight some of the areas that we could focus on. So as I said, I did core training in London. Lots of great opportunities there with tertiary specialties and specialist services, a very strong sort of psychology provision, and I had some great sort of psychoanalytic experiences that really provide the bedrock of my future practice. So obviously a lot of funding and money and research in London that is difficult for us to match in the regions, and particularly rural and coastal areas. And I think increased competition, as we saw those incredible statistics of sort of differential competition rates, that really, I think, plays out in the trainees, and perhaps leads to a slightly different energy in the training group. Not always bad. I think some people are attracted to perhaps, you know, less competitive areas for good reasons around sort of work-life balance, but it certainly was a different energy. Of course, experiencing urban psychiatry with a more transient group, certainly higher rates of psychosis, more diverse, and busy inner city hospitals, gave me a really good grounding in terms of my training in core training. But was busy, was hectic, was stressful at times. And so I started to think about a transition. I was starting to feel, you know, that sense of a transitional sort of a transient population meant there was not so much longitudinal follow-up, feeling a bit lost in large organizations, and looking for some space to grow and work-life balance. And of course, cost of living in London is always a challenge. So I took the decision to transition. I felt that I didn't want to be a consultant in London and wanted to transition for higher training to start understanding the region, and understanding where I might be best placed. And very luckily, I was placed with Veena as my first as a clinical supervisor when I moved up to Lincolnshire. That idea around a sort of better quality of life, more consistent lifestyle, I think, and there's sort of hecticness that you can experience in urban areas, that I was looking for something more consistent to really sort of build my career and build my family as well. I think there was felt much more flexibility of options. I think my experience in Lincolnshire was an organisation that was really keen to make the experience a good one, and so was willing to sort of focus on my nurturing, on my growth in my career, both professionally and personally. And I think it's an important thing to think about if you're someone that is trying to attract trainees to your area, or attract medics to your area, thinking about, you know, what is the unique selling point of your area, of your organization. But always says, you know, if life gives you lemons, make lemonade. And I think it's a really good point. We can sit there and say what we don't have, what we're not in rural and remote areas, but actually there's so much that we do have. And are we shouting about that? Are we attracting people that where those things are really real pull factors for them? As been mentioned, you know, Lincolnshire is a large rural county with a low population density. That does mean there's a lot of traveling, a lot of driving in particular, and trainees that we have that can't drive. It is always a bit of an issue with the lack of public transport. But a big variety of people, lots of diversity in social class, with pockets of poverty, significant poverty and deprivation, as been mentioned. Of course, you know, there is some big cultural differences that I certainly was a bit of a culture shock. I think diversity is obviously low. There is a much slower pace of life. And that sort of separation with the age groups, you don't get so many people, perhaps in my age group, that sort of younger professional working age group. It's more sort of younger and much older, which has been a challenge. I think one of the biggest things I noticed when I moved into the rural area was the staff group being so different, much more drawn for the local community. That did sometimes create some challenges where staff and patients knew each other or had lots of connections. Significant number of international medical graduates, and adapting to that was a really important aspect. Lots of amazing sort of cross-cultural exchanges, but also some challenges as well. And then I think just differences in presentation in terms of rural mental health problems, and perhaps more complex trauma, more personality difficulties, less psychosis, which I found really interesting and exciting, but it was certainly different. And I think in terms of access, you know, nothing is right on people's doorstep. There's always going to be challenges that increases, you know, those health inequalities, reduces access to community services, and obviously a lot of professionals that we can struggle to attract to rural areas, meaning less psychology, for example. But I really enjoyed building some great relationships, collaborating, connecting with people, connecting with the wider community, suddenly feeling a real part of the community, and starting to sort of embed myself in that community, not just in work, but also in my personal life. And I think the two were much more in tandem than they had been when I was living in London. Some challenges, certainly reduced anonymity, as I've mentioned. I came across people, or was connected to people that I was treating, and that was an interesting experience that's so different to a big city in London, where you feel very anonymous. Workforce challenges, as I've mentioned, with the medical workforce. And you know, hopefully events like this can help attract people into rural areas, but I think, you know, medics on the whole are sort of urban creatures a lot of the time, and persuading people of the joys of rural life can be a challenge. I think it's really important to recognize that opportunities don't always fall in your lap in rural remote areas, but if you go looking, there's so much out there. There's an abundance of opportunities. That's certainly what I recognize. I think I do really recognize sort of my intersectional privilege, and the ability to sort of make the most of the situation that not everyone has. But as a gay man sort of leaving London, that was certainly a bit of a culture shock for myself. So that's been an interesting process as well. I think there's always going to be pros and cons, you know, isolation and sort of struggle of connecting with colleagues when services are so spread out is always a challenge as well. But there's been lots of positives and lots of joy as well in making new connections. Of course, what we all do this for is working with patients, and I think that's been one of the great joys has been those long-term relationships, seeing the longitudinal growth of patients, and really feeling your impact in a way that I think I struggled to do in London. And I have really developed professionally. I've had amazing mentors. I think those statistics about people having more time for you is absolutely true. Time and space to grow and develop, connect with people across the organization, where everyone just has that little bit more time and space for you. I feel like I have been able to sort of find that space for my family and myself to grow. And again, sort of connecting with the community and feeling that sense of place and sense of community has been a real joy. So it's a bit of a whistle-stop tour. I think, like I said, it's a personal choice for everyone. But I think, you know, trying to encourage people thinking beyond the obvious of what might attract people to rural and remote areas is really important. And the opportunities are there for the taking. And I really encourage everyone to sort of strive for that. I just want to leave everyone with a bit of a poem. Perhaps we may not have time for me to read it out, but it's a beautiful poem about taking the different path and how that can have a profound impact on your life. So I'll leave that with everyone. And thank you so much.
Thank you, Toby. Thank you so much. Okay. The next talk is going to be Living Our Best Training Life, Remote and Rural. So we have Rosemary Gordon, who's an ST6 trainee in Southeast Scotland. She was the previous chair of the PTC. She's current vice chair of RCPsych in Scotland Careers and Workforce Committee. She's keen on improving the experience of trainees. And we also have Dr. Brooke Marin joining us. Brooke is a CT2 who's doing the West of Scotland training program. She said doing this training program has allowed her to travel far and wide. Most recently, she traveled to Loch Gilphead, which has led her to develop more of a passion to promote the benefits of training in rural locations. So over to Rosemary and Brooke. Brooke, I hope I pronounced that place correctly. Thank you. Over to you.
Perfect. Thank you. Just wait for our slides. Next slide, please, Georgia. So I wanted to start by kind of talking about why we got asked to speak here today. And I've got to say, I got the email asking if we would speak at this event. And I went, but I work in Edinburgh. Edinburgh's not the one Wirral. What? But actually, lots of my jobs have been in the borders, both in my GP training and in my psychiatry training. I live in the borders. I have moved an entire 6 miles away from the house that I was brought up in. And I absolutely love working and living in the borders, and actually plan to take up my consultant post in the borders in the next couple of months. But Scotland itself is relatively rural, but there is differences kind of throughout the country. So I thought it was important to showcase Scotland as a whole. So asked Brooke if she would kindly join me today to talk about some of her experiences as well. So you've got a bit of a core training and higher training feel to our talk today. But I thought I just would start by putting things in perspective a little bit. Next slide, please. So geography was never my forte at school, but I thought I'd have a little look at actually where do we fit in the side of things. And everybody always compares everything to London. So London has a size of 607 kilometres squared. Now, as you can see in that first pie chart, that is a tiny amount compared to Scotland, and actually both the health boards that we're talking about today. So the Borders is almost 2,000 kilometres squared, and the Highlands is over 1,500 kilometres squared. And in comparison, the population is basically inverted. So the Highland population has a population of 32,000, and the Borders has a population of 115,000. Scotland as a whole has a population of 5.45 million. Now that is compared to London's 8.9. So in area, we are very vast. In number, we are quite small. So that's just kind of to put things in perspective. Next line, please. Next slide. So what are we going to talk about? So I'm going to talk very briefly about my training journey in South East Scotland. Brooke is going to talk about her experience in NHS Highland, and then we're going to spend the majority of the talk speaking about the motor neural Mythbusters. So actually, why we genuinely think that training in the motor neural areas is a fantastic training experience, why you should certainly think about it, and hopefully putting to bed all the myths that people think about, oh no, I wouldn't want to do that because. Next slide, please. So this is literally going to be my 2 minutes on my training journey. So as I've already said, I was a GP before I went into psych training, and tomorrow is my last day as a veg before I take up my consultant post. So I have a lot of years of training in South East Scotland, a lot of which has been in the Borders. But I'm particularly going to focus on my higher training, of which my ST5 and ST6 were both in the Scottish Borders. I absolutely adored these years. I got to see lots of different pathology. I got involved in lots of things, both within Scotland and the wider UK. And I got to see how actually, as a consultant, I could work in an area that is so big, but ensure that my patients get good and appropriate care. We spoke a little bit about digital literacy earlier, and certainly in my ST5, we did things like my CPNs would go out to iMouth and Coldstream, which is practically kind of sitting on English Borders, and other CPNs would go to kind of Peebles, which is almost Edinburgh. It really is a vast area. And we would do Teams calls. So often, this was my addictions job. So my patients, they, deprived areas, deprived patients, didn't have the accessories, didn't have the laptops, the phones to do video calls, but we would take that to them. And actually, we really were innovative with the technology and how we make sure that we care for our patients. We have drop-in clinics in all the big towns once a week. And when I say big towns, I'm talking about like populations of 10,000 people. Although Galashiels does have a nightclub. I have never been in it, but it does have a nightclub. But the things that often feel like they're challenges aren't. They are opportunities to change things, to get things done. There's minimal red tape in a small health board compared to a massive health board. It is so easy to try and push something through to make things better for your patients, to look at those things that many people would call obstacles and go, actually, what can I do about that? Let's have a drop-in clinic. Let's set up an IT cafe. There's so many things that we can do. And you do get to see a little bit of everything. So I think back to my ST4 clinic, and my first patient would have an eating disorder. My next patient of the day would have a schizophrenia. My next patient a bipolar. The next patient a personality disorder. My next patient might have a borderline LD. My next patient might have a forensic history. You see a little bit of everything in every day. And I think when it comes to psychiatry, you really are generous within your speciality. So I suppose my take-home message from my training is that I have had so many opportunities and such a fantastic experience during training that I wouldn't think about going anywhere else to take up my consultant post. And I would urge other people to consider thinking about going somewhere in motor neural where you genuinely become part of the team at such a junior stage. You get opportunities that you would never get elsewhere, even kind of thinking back to FY1, FY2 in district general hospitals, getting chest strains, LPs and things that nobody else would get until kind of their core training in medical specialties. There are so many opportunities and it's a fantastic experience. Next slide.
Yeah, so thanks, Rosemary. I was just going to chat a wee bit more about core training in the sort of remote and rural locations. So I think part of being a statistics of where most people stay where they went to medical school. So, I went to medical school in Glasgow, and then stayed and wanted to do my core training in Glasgow. And then up came the opportunity to do a 6 month post in Lochgilphead. Little did I know that was all still sort of part and parcel of the job, and I thought, oh my God, where is that? So just to get a bit of context, Lochgilphead is very far in the west of Scotland. It's part of Argyll and Bute. It's about 2.5 hours approximately from Glasgow, and Glasgow being sort of by far your biggest city. There is still shops and things, but it is very rural. So it was an interesting post, and I think probably very unique and unrecreatable elsewhere, but if you can kind of follow the map, I've just given you a rough outline of what I would do in a week and why it was so much fun. So I would set off from Glasgow. This is a picture outside the art gallery. I'd set off from Glasgow on a Monday morning, and I would then get a ferry. So I would get a ferry over to, you can probably see on the sort of middle bit of the map, Bute. So I would go over to Bute, where I would do sort of a general adult outpatient clinic. I would do this with two of the CPNs who have lived on Bute for 20 years, and they would pick me up from the ferry. We'd then go out, we'd go do lots of home visits. The island's very small, very easy to get around. And I think you get a much better picture of patients in their own house compared to when they come to clinic. I think that's very unique about sometimes rural posts, as you go to them rather than they come to you. I would set off with the CPNs. We'd go around everyone's houses, and very similar to Rosemary, one minute you'd be visiting someone who'd been on the caseload for 20 years with schizophrenia. Next thing you know, you'd be doing an ADHD assessment. Sometimes you get called by the A&E or the police because there was drug-induced psychosis on the island. Everything and anything would come through you because you're the only port of call. Never a dull day, never quite knew what you were going in for. And the island itself only has a population of about 4,000. So how people were still every week getting referred to be seen by psychiatry blew my mind, but we were kept busy. So that was a Monday. And then I would set off from Bute and get another ferry. So I get a ferry around to Lochgilphead, which is the sort of main hub of Argyll and Bute psychiatry, where the hospital is. Now, the hospital was our base where all the trainees and all the consultants for the region are based. So the team was made up of 4 consultants, and then you had 2 core trainees, and that was it. No higher trainees, no nothing in the middle between you and the consultants. So a very flat hierarchy, very close team, very close to the other core trainee as well. And it really meant that the decisions fell to you. You didn't have your reg to run things by, which can be quite daunting, but also it meant there was just a lot more opportunities, and I think you got to experience a lot more. So on a Tuesday I'd be in Lochgilphead, do sort of inpatient work. Again, I think when you go to these rural places, I think Toby was saying you get quite enmeshed in the society and the community. That's definitely true of Lochgilphead. It's an interesting town. It was one of the last asylums in Scotland. It used to have sort of 1,000 beds. It's now down to 12. So everyone that was in the asylum lives in the surrounding areas, which leads to interesting appointments in the co-op occasionally when you're doing your shopping. But so I would do my inpatient work on a Tuesday. Then from Lochgilphead, I would travel all the way around to Inverary, pick up a coffee essentially, to then work all the way back around to Dunoon. And I would spend the rest of the week doing clinics in Dunoon. And again, just to highlight the unique opportunities you get there. So Dunoon runs the only ketamine clinic in Scotland. So, I don't know if many other core trainees have got to do that in Scotland. And again, because there was no reg, that was something I got to do and really, really enjoyed. I'd finish up in Dunoon, and then again I would get a ferry back to Glasgow, and that'd be me for the week. And I would do it all over again for the next week. And out of hours, when you were on call, I would cover the whole region. So I would also cover sort of Campbelldown, Port Ellen, and Mull as well. So it was a really, really interesting week. So we were just that's a brief overview of what the week was like. And we were just going to quickly do some mythbusters about rural training. Next slide, please, Georgia. This was just my route. These are just some pictures to give you an idea. I mentioned the hospital. So that's the asylum, which is still very much on the site. And then down the grass, they've built the new hospital. So you've got all the social psychiatry history and action when you're physically on the site. Next slide, Georgia. And the next one again. Yeah, next again. So just for some mythbusters to finish off. So I think people were highlighting here earlier, some people think in rural locations there's nothing to do, which I can see how you can think that, but actually, Argyll and Bute is absolutely beautiful. There was walks everywhere. That was this picture of my yoga studio that I used to go every week. There's a picture of there was a local woman, Polly, who ran like a coffee shop place that everyone in the town went. And there's a picture, you may be mistaken for thinking it's Australia, but actually that's in Gourock, beside the ferry terminal. That's the sort of heated outdoor pool that I used to go to after work once I'd been on the ferry. Next slide, Georgia. Yeah, this is just some pictures from Bute. So there was a glorious day on Bute where none of the patients wanted to be seen. They all called in and cancelled their appointment. So I got to walk around Bute. This is Mount Stuart House where Stella McCartney got married. So there's always gems to be found in all of these places. Next slide, Georgia, please. Next slide, please. Yeah, and the traveling is terrible. I think we've heard a lot today about commutes and long distances, but I loved traveling around Scotland. Who else gets that's my money on the ferry. I love the ferry. Other pictures from the drive up to Dunoon. I used to stop and have we walk on the way up. So I think sometimes these things are how you view them, and I don't think having a long commute is always a disaster, in all honesty. Next slide. Yeah, and I think Rosemary's going to do the next few mythbusters.
So I think there's a theory that there's no good psychiatry, that actually to get that really good going forensic psychosis, you need to be in the middle of a big city like London. And that's just not true. Lots of these places have tons of deprivation. They have a lot of adverse childhood events. And actually, as much as there is this kind of city pool with major psychiatric diagnoses, we do see plenty. And that is all that variation as well. So don't think that actually going to the more rural places, you won't see the things that you do in big cities. Don't think that it's not as interesting, because it certainly is. And often a lot more of that comes to you because it doesn't go to third sector. And you also get to see things before they get unmanageable. You get to do early intervention, you get to really know your patients, and that is incredibly important. Next slide. So I think similarly, there's this theory that you become de-skilled, and you certainly don't. You see everything and everything because there aren't tertiary centres. We're not sending our patients 400 miles away because they have an eating disorder and they need to see the tertiary centre for it. All of this stuff gets done within general adults. So eating disorders, perinatal, personality disorders, neurodevelopmental, psychosis. And you have the mix of kind of inpatient and outpatient. So most of the motor neural areas in Scotland still have an inpatient, outpatient mix when you're a consultant. On the whole, we have beds, which is wonderful. So none of my patients sit in A&Es for 24, 46, 52 hours. Most people get a bed very, very quickly, and hopefully kind of within the area, certain in the borders. I don't remember the last time we genuinely didn't have a bed for a patient. So there's lots of opportunities, and you don't become de-skilled. You just have a much wider baseline knowledge of things. And we still, we'll send patients to Dundee, which is our advanced intervention service, or the Maudsley if need be. And finally, there are no opportunities. So personally, I think, working in any of these areas is an opportunity in itself, but there are hundreds of opportunities. There are less trainees, so actually you get more support. You really get to design your own training so it really suits what your educational needs are. You have much more input in where you're going to get sent, what you're going to do. And there's all these other things that you can do. Lots of my friends have done PhDs. Not my bag at all, but lots of my friends are doing PhDs. There's lots of opportunity for research. I became chair of the PTC. I talk at things like this. I'm speaking at Congress. I do lots of educational things. I teach our advanced nurse practitioners. No matter what your kind of outside interest is within medicine, whether it's education, research, leadership, there are opportunities in all of these places. You just need to ask for them. So I think that is our Mythbusters. we are more than happy if anybody's got any questions about either our own experience of remote and neural medicine, or working or living in Scotland, then Georgia has our contact details, so you can send us a wee email. That is not a problem.
Thank you, Brooke. Thank you, Rosemary. It was really important to, to address those myths, to really bust them. Thank you so much. And now we have a recording. This recording is a rural psychiatry roadmap by Dr. Stephen Bleffery. He's the Director of Training for Rural Psychiatry in Western Australia. So over to Dr. Stephen.
Hi there, my name's Dr. Stephen Bleffery. I'm a rural psychiatrist in Western Australia, in the southwest region of Western Australia. Thank you for inviting me to your webinar today. I understand you've already been hearing from some excited rural people trying to promote the advantages of working in the rural areas. We've been doing a large body of work here in Western Australia to increase training opportunities, and I'm going to spend the next 15 minutes just explaining to you our journey on how we got here. Before I do that, I would like to acknowledge the traditional custodians of the land of the offices here in Bunbury, the Wadandi people of the Noongar elders past, present and future. So our journey in working on increasing rural training opportunities in psychiatry began with a big body of work from our binational college, the Royal Australian and New Zealand College of Psychiatrists. They did a wide-ranging stakeholder engagement to try and lay down a roadmap to try and address the issues of having less psychiatrists in rural regions in Australia. In 2021, they came up with the Rural Roadmap, which is a really good document that outlines the actions required across both the college, but also governments and health service providers in how to increase those opportunities, as I say. Happy to share that document with you guys. Basically, it works on trying to fill in the missing link. In rural areas of Western Australia and other parts of Australia and New Zealand, we have medical students, we have interns, we have junior medical officers, and we eventually have some rural psychiatrists, though we'd like more, and we really need to plug the gap. So we have this, what we're calling an end-to-end training program, because we know that if we train people in the country, they're more likely to stay in the country. In the roadmap, they identified this rural cycle of rural disadvantage. And so we can see that it's a bit of a toxic cycle where there's an inequity of access to services and poor rural outcomes that is contributed to by having a metrocentric medical education system, underinvestment in rural psychiatry and training and supervision, which means you have fewer trainees, which means you have less access to services. Similarly, underinvestment in services, fewer opportunities, overstretched workforce, chronic workforce shortages, which again leads to inequity of access. During the process of us picking up this roadmap, we had a look at rural WA specifically, and we did a lot of data, did a lot of look at the numbers, and we could see that psychiatrists per 100,000 people across a number of different countries. In Australia, it's about 13.7, and in Western Australia in total, it's 13.5, but in rural WA, outside the metropolitan area, there's only 6.3 psychiatrists per 100,000 people. So that was giving us the impetus to do something about that. Most of you have probably seen this before, a map of Australia and New Zealand. We have, on the back of this rural roadmap, set up a dedicated rural training zone, which is everywhere outside the metropolitan area within Western Australia, which is a vast geography. There's 2.5 million square kilometres in rural WA, and there's only about 500,000 people. So we, in the start of last year, 2023, set up a rural training program, and we have sites dotted across that Western Australia, where we have trainees, and I'll dive into that a little bit more in a minute. But if we just zoom into the northwestern tip up in Broome, you may have heard of. This is an example of a document that we've put together in what we've done to promote rural training. We've done a showcase of each of the regions, and so this just sort of gives you a zoom in and understanding of the place. And you can see that the distance between Broome and Perth, which is the metropolitan area, is about 2,200 kilometres, which is the equivalent of London to Athens. If you go further away up into Wyndham, where the population is quite small, but there are patients to see, that's 3,200 kilometres from Perth. And me being the director of training for a rural training zone now, I have trainees up in Broome that are over 2,000 kilometres away from me. And so I'm travelling up to see them, which can be exciting. So more of the data that we put together when we were trying to justify both accreditation for a rural training zone, but also funding sources. We used a national mental health service planning framework to work out exactly how many psychiatrists are recommended for rural WA, which we came out with a figure of 69 across these 7 different regions. And we only currently have 26, so we need a fair bit more. And then also highlighted that only 54% of the established positions actually filled with permanent staff, and that 47% of the workforce is actually locums or contractors. We're identifying that the metro-centric training program that existed in Western Australia and a number of other places in Australia similar had its limitations in its ability to service and populate the rural regions with psychiatry trainees and the medical workforce. Most of the WA trainees prior to our training program weren't completing rural terms, and even if they did, they'd often come for 6 months and then return to the city. We identified that of the 50 who had graduated in the last 5 years, only 4 of them ended up becoming working in rural WA. There's been a strong interest in training, but as you can see here, very briefly, that we have a lot of applicants into training, into psychiatry specialty training, but only a small number of those actually get into the training program. So so we're going to do something about that. So when I started in this role in 2021, and on the back of the rural roadmap, you can see we had a number of, this just demonstrates that the number of accredited training posts that we had, and we put a concerted effort into increasing the number of training posts that were available and accredited by our college. Unfortunately, you can see that they weren't all filled though. On the right-hand side, they're only filled by, and sometimes only half of those accredited posts. And then even when we increased our number of accredited posts, that didn't necessarily then unlock an increase in trainees into those positions. The journey from there to now is a bit of a whirlwind tour, to be fair. We've done a lot of work in our WA Country Health Service, which is WACS. We have been lobbying at multiple different levels through government, through college, and ended up basically in a journey over the last 2 years to have our own fully fledged rural training program. So once we got accreditation, that was one part of the journey. The next part of the journey was more around how do we fund this? If we're who's going to pay for an increase in number of doctors? And so we were quickly able to identify that there actually already are doctors seeing patients in rural placements, but they were predominantly locums and expensive ones at that. And so we were able to identify that for one locum psychiatry registrar, if we brought a trainee in, it was much more cost effective. And over 3 years in one particular region in the southwest where I'm from, we could save over $1 million a year. Rather than sort of banking that savings, we were able to see that and increase the number of trainees in that region significantly. So this slide here demonstrates that we were able to, after we started our program in 2023, you can see the numbers have jumped up for an average of about 6 or 7 trainees through 19, 20, 21. And now we're looking at, for next semester, starting in 2 weeks' time in February, we'll have over 30 trainees working outside of the metropolitan area in Western Australia, which is really exciting. As I said, we're broken up into 7 different regions here in WA. We have trainees based in the bigger centres where they can do, we're calling them now comprehensive training hubs, where they can do all of the 5-year fellowship program that our college runs in Albany, Broome, Geraldton and Bunbury. And we also have some other opportunities in smaller sites where trainees can go and do some of their training. We did a lot of work in the promotional side of attracting people to our training program, and it's already oversubscribed. But we did a lot of work in, like I mentioned at the start, showcasing each of the regions and what they've got to offer. And we created a document of a program overview, which outlined for trainees who may want to come to us the advantages of coming to those regions. And so this is just a snapshot of that. Which I'd be happy to share with you guys as well if you wanted to use that. Then the final piece of the puzzle, I guess, is we've got those trainees now. We've increased significantly, and now it's about the product and the support that we provide people in rural regions, because we understand that there can be things, particularly over the vast geography of Western Australia, the isolation that comes along with that. And so we are really committed to supporting the trainees and their families when they come into rural regions, and we're aiming to foster a positive and supportive culture. We're pretty big on pastoral care. We have lots of supports and lots of different contacts. We've set up dedicated WhatsApp groups, for example, for the trainees to contact me as their director of training. We hold regular monthly video conferencing town hall meetings where we can talk to them about progress and exam supports and things like that. We're really big on that support, both for the trainees but also for the supervisors, because we've increased the reliance on supervisors in rural locations significantly as well, and we want to support those guys. We've got lots of independent support and crisis pathways. We've got lots of peer support and mentoring. We have very attractive accommodation and relocation packages to support those guys. It could be quite expensive moving to the country. Lots of education support, lots of resources, and probably the jewel in our crown at the moment is our orientation program. We are flying our trainees that are now will be 30 across the state into Perth at the start of the year for a weekend. That is equally networking and social events as it is educational and training support. So these guys can come into the city, meet each other, network, and then continue those networks when they go back out into their regions for their training semesters. And that's been really successful. It's great fun. Everybody looks forward to it, and it's actually drawing trainees to our training program. Though I thought 15 minutes wasn't a long time, I've finished on time. Thank you so much for the opportunity to talk. If anybody wants any more information on what we've been able to achieve here in rural WA, my email address is there. Feel free to contact me, and happy to answer any questions. Thank you very much.
Absolutely mind-blowing account of the extent of planning, the strategy that's gone into it, and the way in which it's been implemented and the scale in which it's been implemented. Quite inspiring, actually. So a big thanks to Dr. Bleffery, Dr. Stephen Bleffery and his colleagues. We have a lot of lessons to learn from them. Also, big thanks to Toby. Toby, your experiential account on transitioning from a city boy and finding a fulfilling work-life balance and a work life and a personal life in rural Lincolnshire is really, really a testimony to what we've been saying along. And Rosemary and Laura, brilliant account, lovely, rich narrative on busting the myth about training in rural areas. I don't see anything in the question and answer section except what Subodh's written about. Accommodation relocation packages look like. Is it only for trainees or trainers too? Well, it's I think it varies from trust to trust, doesn't it? we used to have an excellent relocation, specific recruitment and retention package, but because of financial pressures, that's been taken away. I think that varies from trust to trust. Anything else that Toby or Rosemary or Georgia wanted to add to that comment? Because that is important. That goes back to the point that we were making about incentivizing trainers and trainees, and that's important. Anything to add?
I didn't know whether Subodh was maybe referencing the Australian example. It'd be interesting to get the figures and see how comparable it is to the packages that are available here in the UK.
Absolutely. I think we want to keep in touch with them and learn lessons from them, including looking at what they offer. Absolutely. So I hope the takeaway message is that training in rural and coastal areas can be very fulfilling emotionally and practically and in every way. And there are lots of opportunities. And yes, it's that's the takeaway message. I hope people are open to that. Thank you, everybody. Thank you.